Who the Coordinated Care Network is, why it was created, from both the perspective of why there's so many different agencies involved with it, but also why the state created it. So just a real quick overview. Coordinated Care Network, there's actually 8 different agencies involved. 6 of us are affiliated partners: FAMSI, Bay State, Child Family, Duffy Health Center, High Point, and Stepping Stone. Then we have like a little bit of uniqueness to us that we have material subcontractors. Our material subcontractors are Brockton Neighborhood Health Center and Community Health Center of Cape Cod. And our model is a little bit different that the other BHCP projects in the state actually don't have material subcontractors that I'm aware of. And the reason we have 2 material subcontractors is we were approached by one of our ACOs, which you'll hear about a little bit later what an ACO is and what they're trying to do. But they are actually part of an ACO, but they're also providers of behavioral health services. So we decided to form a unique partnership with them to kind of test a different model of providing behavioral health services inside an ACO. So we'll jump right into a little bit of background and terminology here. We actually will hand out all the slides to you later on. But just to kind of give you some global understanding, the MCOs, managed care organizations, are mostly everyone familiar with an MCO is and what they do? Not really? No? A managed care organization in Massachusetts on the Medicaid side has been around for over 20 years now, and basically it's an insurance company that's managing lives. In our case, the whole focus of the BHCP project is Medicaid members. And for many years, Massachusetts had like 6 different managed care organizations, but they did a big reorganization of the system and really downside the number of managed care outfits out there. And today, we're really working with 2 managed care entities and then another group that's managing the PCC plan. And the 2 managed care entities are BMC, which is really part of Boston Medical Center, and the other one is Tufts. The other group out there is called MBHP, which is the Mass Behavioral Health Partnership, and they actually are managing lives that are part of the PCC program, which is divided into 2 pieces. There's a behavioral health component, which we're part of, and then there's a primary care component. On the other side, Tufts and BMC, those entities technically are responsible for both behavioral health and primary care underneath one roof. But even that is not simple because there's actually Tufts, who manages both sides under one roof, and then Boston Medical Center, BMC, HealthNet plan, actually has a carve-out, which they have another entity who comes in and manages the behavioral health benefit called Beacon Health Strategies. So you can kind of see that it gets really complicated really quick, even with a small number of players on the MCO side. Now, the MCOs is more structured to that when it comes to BHCP, that the Behavioral Health Community Partner Initiative is part of another reorganization where they created accountable care organizations. Now, the accountable care organizations really, for all except for one, are actually hospital systems. And a lot of the systems you're probably very familiar with. Stewart Health System is one of them. They are one ACO. South Coast Health System is a second ACO. BMC, the health care side of it, the hospital side, is another ACO. And we're going to kind of go over the ACOs that are important to our initiative in a few minutes. But the other pieces on this slide that are important is the 1115 waiver, which is something that you really don't need to remember about, but the whole BHCP ACO program is actually from our 1115 waiver. And what the 1115 waiver is, briefly, is it's really our relationship to the federal government on how we manage Medicaid lives in the state of Massachusetts. And every state negotiates with the federal government on how they're going to provide services to the Medicaid population. And every state is unique that they will ask to do different things with the population. In the case of Massachusetts, in our most recent waiver, the ACO BHCP program is really the basis of that waiver. So we have a waiver from some of the traditional Medicaid rules from the federal level to basically do what I look at as a great big experiment. So really, you are part of a very large experiment where Massachusetts is trying to improve the quality of care provided to MassHealth members, at the same time trying to reduce the cost of that care. So it's an extremely big challenge, quite frankly, and we really are going to learn a lot together over the next 5 years. The waivers are 5-year blocks of time, and we're pretty excited about trying to really figure out how to do things different, better, and really improve the outcomes for the members that we're serving inside the Medicaid program. So hopefully it will be a real positive experience for both everyone here in the room, but also to the members that you're going to be serving. So I don't know if we use this term a lot today, but social determinants of health. As we begin moving into the actual BHCP project, you're going to hear that term a lot. The work you're going to be doing, coordinating care, part of what you're going to coordinate is trying to help folks who really have a lot of other social needs connect and have those social needs met, which certainly on the clinical side, all the 8 agencies that are involved try to do a little bit of that work. But the reality is the main focus of like an outpatient clinic is trying to meet the immediate clinical needs of the client, and you really don't have as much time as you like to do to really always delve into all the social needs of those clients. And certainly we're hoping through this initiative that we can better address some of the social needs, and of course by that affecting the outcome of health for the members. So, system transformation to the ACOs. District is a $1.1 billion investment that's being made. And the district funds, again, we'll talk about a little bit more detail in a couple of slides from now, but the reality is the short definition of what district money is all about, it's really an extremely large investment in the infrastructure of healthcare here in Massachusetts to try to change the way we deliver healthcare, that over the long run, that this district investment actually will go away at the end of 5 years, but the new structure that we created will become self-sustaining. So again, another real unique part to the initiative we're starting, that we really never had a project that we've done, particularly working with the Medicaid plans, where Medicaid's coming to the table, investing an extraordinarily large amount of money to actually help us change the system. So it's kind of cool. So I realize you cannot see this slide, and that's okay. But the reason I asked them to put it in the slide deck is just to kind of spend a little bit more time talking about district money. Not going to get into a lot of details, but it's one of those things that if you're at a meeting and they start talking about, your managers in particular start talking about, district money and how we're investing that money, I'd like to have, for you all to have a little bit of background on it. The other thing about our district money is we haven't technically spent all of our district money yet. And I'm pointing it out to you because there's limitations on what you can use that money for. And in the case of the CCN network, for year one in this project is June 1st to December 31st, we're receiving over $2 million of district money. And it's critically important that we figure out the best way to spend those dollars to have the largest long-term impact on the folks we're going to serve. So over the next few weeks, and really even over the next few months, as you begin to provide in services, it's really important that you give us feedback on things that we should be doing with our district money to improve the outcomes of the work that you're doing. So again, this is a real quick overview, but there's like certain buckets that you can spend the money in. The top one is technology. And technology could be the software that you're going to be using for the project. That is certainly one of our investments in district money. If we choose, we could actually go out and buy an app. We could buy other software to support the initiative. We could build online resources. So, you know, you start thinking about technology today and everything that's going on in the world on the technology side. We are certainly hoping to identify other initiatives where technology could help the members sustain their health in the community. The next bucket is workforce development. And workforce development, again, there's a lot of options there. A few that we're looking at now is you know, the ability to use some dollars for loan forgiveness to help folks that are newly out of school or folks that have been out of school and still have some debt. Training. So again, as a project gets going and you say, you know, we find that there's some unique health issues that we're finding in large numbers that we might need to bring in additional trainers to get everyone up to speed on meeting the needs of that population. Retention. I know we're using a few dollars in retention because we do realize that this first year of this project is going to be tough. You're going to get frustrated at times. You're going to feel like, oh, you know, why wasn't that done before I started working? You know, why is there a glitch in the software? So you're going to run across a lot of challenges in a new project that obviously we're hoping that we can collectively work through together. But certainly this is a startup. And it's a complicated startup because we literally have 8 different agencies that are involved in this startup. And we're going to be operating probably altogether out of 15 to 20 different locations. So it's not like they're even all together to work as one large team. We literally are going to end up with eight agency teams, but then inside some of those agencies are then going to subdivide even the smaller teams. So you can see how it can get pretty complicated, even communication between the CCN network. The business startup cost is pretty cut and dry. It's really about the ability that we can go out and buy desks and other furniture to get the project off the ground, office supplies, etc. And operational infrastructure really is the administrative team to make the project work. So those are the main buckets. And again, you'll get the slides, but definitely try to keep in mind really the technology piece more than anything. That we're hoping that we can find some additional tools that will help you do your jobs a little bit quicker, a little bit easier, and support the clients. So, a little bit more in district. Year 1, I said we're going to get over $2 million in district dollars. Year 2, it's actually going to go a little bit higher. Year 3, it's going to start going down. Year 4, it goes down more. Year 5, it goes down extremely low, and then it goes away. But even inside that 5-year project, we have a lot of quality measures that we're going to need to meet as a group. And ironically, if we don't meet all our quality measures, they actually are going to take. some of our district money away from us. So it's just another overlay of the complexity of the project, but the district money is not guaranteed. The only dollars that are guaranteed to us is the monthly per member per month that we are being paid to do the work. And for the BHCP clients, it's $180 a month. That's it. That's the total amount of dollars, $180 a month. So you can do the math and see how much money is coming in at $180 a month. Not a lot of dollars. We do have a second group of clients through the ACCS program, which was called the CBFS program through DMH. But as of July 1, it's switching over, and really that's a program that's always been in a partnership between community providers and DMH to work with the DMH population on case management. And for that group of clients, we're being reimbursed $250 per month. The ACCS part of the project is actually exclusive to BAMSI because it was a different RFR that they responded to, but is part of the whole BHCP initiative. I know there's a lot of pieces. So how they're going to be measuring how well we are doing is prevention and wellness. It's 5% of our measure, and it's prenatal care annual wellness visits. That one hopefully will be a pretty easy one because the whole BHCP project is based upon we as behavior health providers working in partnership with primary care providers to coordinate their care and better meet the needs of the members. So number one should be one of the easiest ones for us to meet. Behavior health, chronic disease management kind of goes right along with our relationship with the primary care provider. The behavior health is the third one. And interesting, you think that would be an easy one because all the agencies that you're working for are behavior health providers. But the reality is there's a shortage of psychiatrists, there's a shortage of clinicians, many days there's a shortage of psychiatric beds, detox beds, rehab beds, and we have this measure up here which is 10% of our score is initiation and engagement and follow-up after hospitalization. And that is one area that, again, as we're learning, hopefully we could figure out some ways to collectively improve the systems that you all work for and how we can better integrate the service side of our organizations into the behavior health initiative. But it's definitely going to be a challenge because most of the agencies involved in the project already have difficulty having enough space in their clinics to meet the needs of clients. So that, hopefully a lot of lessons learned from this group. Member experience, access, care planning, participating care planning. Again, this is something that we'll be measuring very quickly on the project as you're reaching out to clients. How many clients do we initially engage? How many clients actually sit down and sign the consents? How many move on to do the assessment and then finally do their treatment plan? So there's multiple steps in the process. The nice thing is the software, the Care Navigator software has good tools in it to help measure that progression that should make at least knowing where you're at a lot easier. Integration kind of falls right into the behavior health conversation. Avoidable utilization, readmission rates. It's interesting at some level that Medicaid did not give that a heavier score than 10%. The reason I say that is the whole goal of this project is to reduce cost and improve outcomes. And the biggest way we're going to reduce cost really is around unavoidable utilization, particularly of acute care beds. So again, trying to look at and understanding the system is going to become an important part of what you're doing. And when you have a client that you're coordinating care for, and where they're at currently is not meeting their needs. For instance, they have a crisis going on in their life, and the concern is that they might decompensate and end up in a psychiatric bed. How can we intervene earlier? How can we maybe put them at a lower level of care, why their symptoms are not as acute, to avoid that acute admission? So it's the same thing on the addiction side. Somebody has a slip used for a day. They don't immediately need to go into an acute care bed. What services are out there that would make sense to meet the needs of that particular client? So again, we certainly understand it's going to take you quite some time to kind of get up to speed on all the different levels of care, all the different services. You're going to definitely be relying on the managers of the CCN project to help figure that out. At the same time, we recognize you're going to need additional assistance from the actual operating side of the 6 entities that you're working for. To you can pick up the phone and call someone and say, hey, this is what's going on with the client. Can you help guide me on what would be the next best intervention for this member? And the last is the largest, engagement. 50% engagement, which is 90-day assessment and care plan completion. And the reality is that PM per member per month of the $180. At the end of 90 days, if we haven't engaged the client is no longer a part of our project. There's only one little exception to that rule. For the first group of clients we're receiving an effective July 1, they're actually giving us an extra 30 days. So we have 120 days for the first group of clients. However, after that, the norm will be 90 days. So again, we'll have to work through strategies, try to figure out what can we do that you have a client that you can't reach at all. What are the other options of reaching them? What can we do to try to kind of get out on the streets looking for folks? And why certainly there's some thought been put into it already. There's a lot to learn on how we can basically even at times find folks to try to engage the folks to become part of the project. And the 6 agencies actually might even try some different strategies on engagement. That one agency A strategy might work absolutely wonderfully, that agency A will then share their lessons learned with the other 5 agencies. And the same thing is agencies are going to try things that don't work. And again, we want to share that information across the network so we can all learn from that also. But this one does make sense that 50% of our performance is about engagement, because that really is the first large outcome that everyone is looking for from the BHCP project. Make sense? I'm going to stop there for a moment. I know I just threw a lot at you, and just kind of open up these first few slides for questions if anyone wants me to. No, not yet? All right. I know it's a lot. All right, so we'll keep moving. So again, this is going to give you a little more overview of the structure of the ACO project. If you've worked in this system, you have some appreciation of the scope of this change. If you're new to healthcare, it's kind of hard to wrap your head around how big this change is. The first thing here is the primary care exclusivity piece. Really is the fact that members that are enrolled in Mass Health that are part of an ACO, which by the way is the majority of the Mass Health members are now in an ACO, their relationship on their general health care is just with that ACO. And that's a huge difference from before, where a member would have a primary care doc over here in this organization, a specialty doc in another organization, and receive their hospitalization somewhere else. So they really, for their healthcare needs, they really have created a limited network of where they're going to receive care. And when you're working with these different ACOs, besides their behavioral health services, interestingly enough, everyone that you're going to be talking to and coordinating care with is going to be inside that ACO, that you really can't have a member, and the member won't be able to go outside of that group of providers. On the behavioral health side, interestingly enough, the member does not have that same constraint. So even if an ACO has behavioral health services, they're not mandated to use those services. The same token that you will have many members that you're coordinating care for, including in their behavioral health services, that are not going to be provided by the agency that you work for. So it's kind of interesting that the behavioral health world and the primary care, general health care world are certainly currently structured much differently. Obviously, we're all speculating what's going to happen over the next 5 years, and you'll see more restriction on the behavioral health side happen over the next few years. The odds are probably will happen, I suspect. Certainly there's a lot of good reasons to try to keep someone inside a network. You know, you think about communication, because even inside some of these large ACOs, they still might have 4 or 5 different EMRs inside that ACO. That ACO might have 50 locations, because they have a lot of primary care practices, specialty practices, hospitals, nursing homes, rehab centers. So you can see that how complicated healthcare is, quite frankly. Susan does not reply to specialties such as behavior. There are some other uniquenesses out there. Long-term supports the LTS community. There's a lot more flexibility on that side of life also, as well as the behavioral health. Yes. More talk about the ACOs. You can see how important the ACOs are, quite frankly. At the end of the day, you can say we have 3 customers. We have the ACOs themselves. We have Medicare. And of course, we have the member. So the ACO structure, they created 3 different models: Model A, Model B, and Model C. Now, here in Southeast Mass, which for us is everything south of Boston, because our service area collectively is Quincy South, which ironically, many years ago, the state used to call that Southeast Mass, and then they decided to chop Quincy off from Southeast Mass and put it into Metro West, which I thought was kind of strange. But for our world, Southeast Mass is everything south of Boston. We only actually have 2 of these models, the A and the B. The Model C does not exist in Southeast Mass. In fact, there's only 1 Model C in the state, so we're really not going to spend any time on Model C. But Model A and Model B are extremely important to us. We are going to be working with all 3 of the Model Bs and a large group of the Model As. So the model, I'm going to focus on the Model B, because the Model B, the difference in the models is in the Model B, the behavior health services are carved out to MBHP, Mass Behavior Health Partnership. So on the Model B, the behavior health benefit is disconnected from the ACO. The ACO is not managing that benefit. Where in the Model A, the behavior health benefit is part of the ACO model. Does that make sense? So in the Model A, you have all the members are going to be enrolled in either Tufts Health Plan or the BMC Health Net Plan. In the Model B, the behavior health services are going to be in MBHP. So, just to make it a little bit more complicated, in the Model B with MBHP, they have the primary care side to it, and they have a behavior health side to their company. The behavior health side of their company is owned, well, the whole company is actually owned by Beacon Health Strategies, and Beacon Health Strategies is a carve-out in the Model A for BMC. So at the end of the day, a very large number of the lives that we're working with for the behavior health benefits are being managed by Beacon Health Strategies. In fact, I would suspect probably 75, 80%. It's interesting, the state has still not released numbers on those percentages. So we're still trying to figure out exactly how many Mass Health lives are in Tufts versus BMC versus MBHP. But you're going to be exposed to Beacon at a lot of levels when you're trying to coordinate care and get folks into services, because they're the folks who are kind of managing the front door for the behavior health benefits. And obviously continued stays, etc., are all going to fall underneath their side. Now, your group as care coordinators will not be involved in seeking authorizations for behavior health services. Your role is going to just be between working on the communication between the behavior health providers, the specialty providers, and the primary care providers and social services providers. But it's important you know the complexities of the behavior health system, because every member you are serving, the reason you're serving these members is because they're high-cost members with high behavior health needs. If the member didn't have high behavior health needs, you would not be serving them. If their needs were significantly higher on the healthcare side, you would also not be serving them. The ACOs have their whole team of care coordinators for clients that have high medical needs and low behavior health needs. Our teams are designed for clients that have high behavior health needs and low medical needs. Now, when I say low medical needs, doesn't mean that you don't have clients with a certain amount of medical complexity to them. It's just that in proportionate, their behavior health needs are really the largest, in a lot of cases, the largest spend that they have in Medicaid. So I think we covered the main points in this slide. So again, I'm not going to read the slide to you, but when you have a chance, when you get the deck, you can look at it. These are the ACOs and MCOs that we're working with. We noted on the top slide, 1 and 2 are the two MCO plans, Boston Medical Center Health Plan and Tufts Health Plan, public plans. And then the rest of them are our ACO partners. And again, over time, and I don't know if there's really a lot more going to be talked about during the training over the next 2 weeks, to delve a little bit more into who each of these individual ACOs are. But certainly, we will work on getting education materials put together to make sure that you do understand who they are. And even right now, quite honestly, we are still working with all these ACOs on what's called the documented process of how we're going to exchange information with them, how we're going to work with them, who the points of contact are going to be with them. So when I say that this is a startup, it's truly a startup, that there's a lot of things that are still work in progress. And the day we go live, there's still going to be a lot of things that are work in progress. So it's going to be, you know, kind of like building the car as we're driving it. But hopefully we'll, in the end, build a pretty cool car. So these are our service areas. Again, I'm not going to read them individually, but we're covering all of Southeast Mass except for the 2 islands and Quincy. That's our service area. And depending on the agency that you're working for, your members might be all in one service area, or they might be in multiple service areas. You know, we will continue to try to, again, work on developing resources in each of the service areas so you understand, you know, what are out there for services for the members. So again, I'm not going to go through a lot on each of the 6 partner slides and you know, get into any of the detail, but we did include in the deck a little bit about each of the agencies. You know, BAMSI, founded in 1975, 140 programs, 46 cities, serves 30,000 members. It's a big agency, certainly a great partner. Just keep flowing through them. That's okay. So there was a second BAMSI slide. Bay State Community Services out of Quincy, founded in 1991. Again, you know, they have a brief description of the service they provided under the slide. Definitely, it's going to be really important that you understand the member agencies you're working with, that you have a good feel for the services they offer. You know, we'll continue to try to get resources out to you and brochures, etc., on the different agencies. Child and Family Services, actually the oldest agency as part of our group, 1843. That's a long time. You know, again, they're, you know, a very large mental health provider, and they do adoption services. Very, you know, very diverse organization. It's interesting too, they also are the crisis team for multiple emergency rooms that we'll be working with on the project. So again, that in itself might present some unique opportunities of how we can do things different and communicate differently, having one of our agencies actually be a crisis team. So just, you know, as you learn about the different agencies, how can we leverage the expertise of the different agencies to better meet the needs of the clients? Duffy Health Center is actually a federally qualified community health center who specializes in serving members that are chronically homeless. And they're located in Hyannis on the Cape. And again, they bring some really unique expertise to the table. High Point, the largest part of High Point is addiction services. We actually do have a psychiatric hospital. We also have shelters for homeless families and other services that you probably wouldn't normally associate with High Point. But there's a lot of different facets to it, again, that over time you'll get to know. Stepping Stone out of Fall River, 46 years. Stepping Stone, again, is an addiction treatment provider, but they also actually do operate the shelter for homeless individuals in the city of Fall River. So when you start looking through each of the agencies, you'll find like, huh, I didn't know they did that. Because even as I'm learning about the different organizations, I keep finding things, huh, I didn't know they did that. And I'll probably be doing that for quite some time, because you know, every agency involved in the initiative has a lot of different projects going on, some large, some small. And certainly the smaller ones are the ones that you kind of really don't know that they do them until you just kind of come across them. Okay. So, CCN admission process. There's going to be the startup admission process, then the long-term admission process. So let's start with the startup admission process. The startup admission process is next week. We anticipate receiving an Excel workbook from Medicaid that's going to have 3,000 Mass Health members in it. That workbook will give us their name, their address, their ACO, and hopefully a little bit more additional information. What that workbook is not going to give us is which of our agencies provided services to that member historically. But when Medicaid created that workbook, the majority of the members in that workbook are there because they had an historic relationship with one of the 8 agencies involved in the initiative. And this is one of the things we keep going back and forth with the state, trying to get them to give us more information. But as it stands right now, they feel, interestingly enough, that they cannot tell us who the historical behavioral health agency is for that member. So that's going to be our first complication. We are going to know how many members in that workbook belong to each agency, but not which agency. So what I can tell you right now is we've asked for 3,000 lives from day one. So that number comes from us. But the unique thing about those 3,000 members, when we get the final workbook, the majority of them, about 2,500 of those members, are going to be members that were given to us because the state has identified that they've had a significant relationship with one of the 8 agencies over the last 18 months, which is a really good place to start from the perspective of trying to engage members. And we are going to have to, between the 8 agencies, figure out which agencies serve them. So basically what we're going to be doing is taking this Excel workbook, taking a copy of our database of our EMR, and matching them up. And I suspect that the majority of the members will be able to see pretty quickly which agency provided the bulk of their behavioral health services over the last 18 months. And then for a smaller group of members, we'll find that there's 2 or 3 agencies that provided services. Then we'll have to look at who provided the most significant services to that member to assign them. So that's going to be the process for July 1. And we're going to get a second workbook on October 1. But there's going to be another process which starts on August 1st, which as of January 1st will be the only process that we receive admissions through. And that process for August 1st is that each ACO, effective on August 1st, can attribute 20 of their members to a BHCP group, which is a very, very small number. If you look at an ACO, while they vary in size, 100,000 members in an ACO in this project is not an unusual number. So each system can identify 20 members of high need each month and assign them to any BHCP that services that area. Now, in the case of Southeast Mass, there's 5 BHCP groups serving Southeast Mass. So the 8 of our organizations are one of 5 groups. And the ACO literally could take their 20 members and send all 20 members to one BHCP group, or they could divide it amongst 4 BHCP groups. So over time, after we get through our initial 2 lists, our ability to grow the program and serve more members is really going to be based upon our ability to develop really strong, good working relationships with individual ACOs. What I predict will happen with the ACOs is that over time there's going to be less of them, and over time there's going to be less of us. And the reason I say that is, again, on the model ACOs, they're going at risk for total cost of care, including behavioral health. For a population that is very expensive and historically been very hard to control the cost of. So I think what will happen is some of the ACOs are going to say, you know what? We're losing too much money. We can't do this anymore. I'm going to drop out. On the BHCP side, you're going to see BHCPs, I believe, drop out also. And ironically, they may drop out for the same exact reason, that financially the model can't work for them, or doesn't work for them. The other way BHCP could drop out is because over time they don't develop strong working relations with the ACOs, and the referrals go down, and at some point they kind of look at it and say, well, today we're doing okay fiscally, but we can already see the fact that we kind of haven't developed great relationships, that over time we're not going to be able to support this project. So the reality is, the end of the day, the ACO relationships are important, but the most important relationship is going to be with that member. Because if you have a great relationship with the member you're coordinating care for, that they feel that they're receiving value from that relationship and they're having their needs met, by default, the ACO is going to be happy. Because if the member's happy, the member's doing well, the ACO's doing well, the ACO is going to be happy. So those 20 members a month for each month from August 1st through December are going to come through our central intake department in Middleborough. So basically, central intake will take the call from the ACO. Some of the ACOs may fax the information over to them. Other ACOs might electronically send a file through a secure file transfer policy. So there's a few ways to get it, but at the end of the day, they're all going to end in the same place, that there'll be an intake worker looking at a referral saying, oh, okay, I have a member that I need to assign to one of our partners. So the way we're assigning members to the 8 partner agencies are based upon service area. And I'm sure you're, and I don't think it's in our slide deck, but certainly we can make sure that the information gets out about who's serving which service areas. But most communities or most service areas have 2 members serving them. But ironically, there's always exceptions to the rule when it comes to trying to do something this complex. But in the case of like Fall River, it's Child and Family and Stepping Stone are serving that service area. In the case of Plymouth, it's Bamsey and High Point. However, if it's a family member that's part of the CSA, which is a children's initiative, if it's one of the parents of one of those children, Bay State's the CSA provider for Plymouth. So we're going to assign that family member to Bay State because we would like to have the family being treated under one roof, so to speak. There's certainly also going to be exceptions based upon the unique needs of the client. That we look at the needs of a client and decide that one of our partners has particular expertise that are going to benefit that client. Regardless of different service area, they could be assigned to that agency. But those decisions will be made pretty quickly. from the time of referral. Hopefully within 24 hours, the client will move from central intake over to an agency. Then inside each agency, there would be a point person who would then determine which care coordinator that client is being assigned to. Okay. So this process is the only process effective January 1. Today is going to have very little effect on us. Like I said, the list for July 1, we're anticipating 3,000 members. The list for October 1 is yet to be determined. We have a goal as a group of engaging 2,740 Mass Health members by the end of this calendar year. It's an incredibly ambitious goal. So if we are successful in the first 3,000 folks that are given to us, and we engage, say, 50% of them, we'll be at 1,500 engaged members, which, based upon that experience, we'll be asking Mass Health for an additional 3,000 members for October 1. Obviously, if we're more successful in the first 3 months, the list will be smaller. That is our hope to reach 2,740. Ironically, there's no take back of dollars or anything if we don't meet that goal. So unlike some of the penalties on the district side about meeting performance measures, that is not one of the true performance measures. However, it's still a very important goal to us collectively as CCN. So we kind of covered a little bit of this slide already on the system transformation. Community-based entities that help Mass Health members with high behavioral health or complex LTSS needs to navigate care. I mean, that's at the heart of what you're going to all be doing. This is just a short list of some of the things you're doing: outreach and active engagement, comprehensive assessment and person-centered treatment planning, care transitions, health and wellness coaching, connecting to community social and flexible supports, medication reconciliation, care coordination, and care management. Those really are the main tasks that we will collectively be working on as part of the BHCP project. So we included this slide just so you have some idea when Mass Health was looking for partners to provide these services, what type of agencies they were looking for. And in the case of our group of 8 agencies, most of the agencies, if not all the agencies that are involved in this initiative as one network, could have actually bid it to be a BHCP by themselves. And this is the criteria that you had to meet. You had a community-based mental health services, some use disorder services, outpatient mental health. That you had to be involved in sort of an integrated care management project, and you have to have a contract with a major state agency. It wasn't a high bar, quite frankly, for most of the agencies to actually meet, to go off on their own. And the 8 of us technically could have all been bidders. And in the end of the day, the state, we knew the state was going to award 5 contracts as a maximum in each area. But the reality is we didn't join up to work together because we were concerned about, well, will we get a contract or won't we get a contract? The agencies involved, we all joined together because we really felt that for us to truly meet the needs of the ACOs, that us individually didn't bring enough depth of services or size to the table to work with the ACOs. Because one of the things I really haven't shared with you yet is that many of these organizations that are ACOs, did not want this project to happen. So it's another unique factor of what we're going to be collectively experiencing, that you have all these ACOs out there that have been mandated to work with the BHCP providers. But if they were given a choice, a number of them would not work with us at all. Now, not all of them. There are some that are excited about working with us. So, but you do have both groups of ACOs out there. Those that are embracing the idea and others that are saying, this is a total waste of time, a total waste of money, and brings no value. And like I said earlier, for us to be successful, we have to really be a great partner with the ACOs. And part of our strategy, before even knowing who all our ACO partners are going to be, really was that when an ACO calls CCN, that ACO understands the comprehensiveness of the agencies and the services behind that phone call. And I don't think we have a slide on it, but if you look at the agencies and you pull us all together, there's over 5,000 staff employed collectively by the agencies that are part of our initiative. We collectively are treating over 100,000 Mass Health members. We are operating well beyond 200 service sites. And back to the real quick brief slides on each agency, but if you started like writing down all the different services that are being done by these 8 different agencies, it's a pretty incredible list. There really isn't much, well, in fact, there's nothing on the behavioral health continuum that we collectively do not offer. But there's many things that we collectively offer that go well beyond traditional behavioral health services. At the end of the day, our ability to get you folks that are working as part of the CCN project integrated and working with the 8 agencies that you're representing is really going to be the basis to our success and having great relationships with our ACOs. Okay. So we might have hit a little bit of this, but not at this level of detail. So back to that list. The 3,000 lives we're going to get for the July 1 startup. So Mass Health themselves has identified they have 60,000 members that they feel would benefit and be eligible for these services. Okay? And the eligibility is really the first point. Diagnosis plus utilization are really at the heart of it. DMH involvement is the other part of it. But the DMH involvement is only for the ACCS members. That's not part of the criteria for the majority of the members being served. But out of the 60,000 members that they would love to serve, Mass Health believes financially they have enough money to serve 35,000 members. And at that point, quite frankly, what would be happening is that member 35,001 would not be able to get a slot with a care coordinator underneath the current model. So we have no idea will we ever hit the 35,000 number. We don't know if we hit that number, will the savings by the project allow the state to push the 35,000 number higher. So this is basically just a paper exercise done by Mass Health saying, all right, if we had 35,000 members, the majority of them were spending $180 per member per month, how much money do we have to spend, and what does that cost us? That's the analysis. It's very simple. And as you can dig into it a little bit, you go, wow, gee, that's really something to change. And it is. But the interesting thing that our group, as I mentioned earlier, for year one, our target is to serve 2,740 members. So basically what we are saying collectively at CCN is that out of all the lives in the state of Massachusetts, we want to serve 10% of all the lives at the end of year one. Now that number goes up in year 2, year 3, year 4, and year 5. And my concern, quite frankly, is that is MassHealth even have enough members that we could ever reach our ultimate goal of members we'd like to serve in the project. We really are excited about the project. We believe that this project can make a huge difference in the lives of MassHealth members with complex behavioral health needs. So for us, having the ability to have external care coordinators that are working with the service side and the community side to bring everyone to the table is pretty exciting. So this is just a quick slide. We kind of hit upon it, but you know, it's just kind of showing relationships. You know, the ACO obviously being at the top. The ACO is going to make referrals in 2 directions at the same time many times. That they are going to continue, the ACOs continuing to work with the behavior health service side. That they have a member that maybe is in their emergency room or might be in a primary care practice that they identify that need behavior health services, let be a psychiatric admission, an appointment with a psychiatrist. They're going to continue to work with the traditional behavior health system. And that behavior health system is made up of agencies that are part of the BHCP initiative and who are not part of the BHCP initiative. Then of course the ACOs are also going to work with the BHCPs and make direct referrals to BHCP for care coordination services. And like we mentioned earlier, the ACO will also be sending clients out to specialty providers, and those specialty providers at times, as part of the ACO, will also refer back into the BHCP. And then of course the BHCP, I guess we really, yeah, we have the arrow there. The BHCP is going to also work with the behavior health provider, also work with the ACO, and then work with this other group down here, which we just globally marked social service agencies. So basically at the end of the day, there's going to be a lot of communication back and forth. And I'm sure some of these social service agencies also, we probably should have arrows going the other way too, now that I'm looking at the slide going, well, you know what, I'm sure a lot of these social service agencies are already working with the behavioral providers also. And they're working with the specialty providers, and some of them are also probably even working with the ACOs. So maybe we need more arrows. But I think you get it. Okay. So the MCO procurement, I did mention earlier briefly that we had many more MCOs before March 1st, and far fewer today. And the MCOs are the insurance companies, pay the claims, work with the ACOs, and they really are the ACO partners. And on the 2 models, the MCOs have different roles. The Model A model versus the Model B, the MCO roles do change. This was kind of the criteria that the state used on the bottom half of how they pick the MCOs they're currently working with. That's it. So again, I just want this to be on your radar screen, that for each budget period, we will have to create milestones of projects and goals that we're setting as a group. And this is just an example of the first milestones that were set in what we call the pre-budget period, the startup period. And I'm sure that working with your managers, as we set goals for each budget period, that you'll be brought into those conversations, be aware of what goals we have set, and how we're doing with achieving those goals. Okay. And this kind of breaks down the ACO, MCO, CPA agreement in a little bit more detail. Again, I'm not going to read through the slide, but it is really important that, you know, as you ramp up and get involved in this project, this is really day one. So at some level, maybe I should have waited and done this on day 10 or something. But the reality is this is definitely pretty detailed explanation that will make more sense between now and July 1. So we did talk about this already, about how we're attributing the members, you know, geographically, you know, obviously is big, but at the same time, there's many other factors that we are using. And again, that information is certainly something that we'll share with you, so you have an understanding of who's doing what, so to speak. And you know, High Point is running the central intake department, but at the same time, each agency has made a commitment to serve a certain number of clients, and we'll be managing to those target numbers for each individual agency to make sure that each of the 8 agencies are successful. So structure for CCN. We actually do have a separate structure outside of the agencies that you're working for. Each of the agencies you're working for have a whole host of committees inside, but CCN, we have four committees: executive, quality, network operations, HR, training. These committees are staffed by the 6 member affiliated partners, and certainly we will pull in the material subcontractors as we move forward, also in multiple committees. But basically the executive committee is the governance committee. So the governance committee is made up of the 6 CEOs of the partner agencies, as well as an alternative for the CEO for when the CEO is not present. And how CCN is working, even though it's not a corporation, we actually are running it as it is a corporation. That the governance function, the 6 CEOs all have voting rights, and major decisions are made at that committee on the direction that we are collectively moving. And the voting rights are made up by this number of mass health members each agency is serving. At the same time, we wanted to make sure that if you were a larger or a smaller agency, that there wasn't extraordinary influence based upon size. So the minute, you know, using a 100% scale for voting, the smallest vote a member agency would have would be 10% of the vote, and the largest vote an agency would have is 35% of the vote. So most of the agencies are going to be around 20-25% would be like the average, and that's to make sure that everyone has a voice at the table, and you know, recognizing the size certainly makes some difference when it comes to accountability and decision making, but the reality is the partnership is just as important to make sure that every partner feels like they have some clout at the table. The quality committee is made up of all, you know, and all the other 3 committees also are made up of all 6 agencies. The quality committee definitely is going to be a busy committee, because that is a committee that is going to look at how each individual agency is doing or meeting the quality measures. So we'll actually have individual reports for all 8 agencies, and then of course we're rolled up into one large report to submit to Mass Health. Network operations. Network operations early on is going to be an extremely busy committee, because network operations includes really anything to do with the day-to-day operations. They're ones who normally are going to be making a lot of the recommendations to the executive committee of how we're moving forward, what we need to do, what policies we need, etc. as well as that committee is also responsible for the ongoing development of the Care Navigator case management software that you're going to be working with. And then HR training, I think will always be an important component also to make sure that, because we have 8 different agencies involved, that as things change from Mass Health on the expectations, that we pull people together and give them all the same training. So when we're out there, we're all doing the same thing. Okay. So that was the slides. I know I kind of went through them rather quickly, but I also, as we started going through them, I realized this is really your first day together. So it's a lot. So after that, do we have questions? Yes.
You said people are going to be referred geographically. Is that
Yes.
where they live?
Yes.
Geographically?
Yes.
Okay.
Yes. Yeah, generally it would be, and you know, the ACOs, why an ACO might geographically be a large geographic area, they are also limited in their service areas. Some of them more so than others. For instance, Signature Healthcare is one of the ACOs. It's actually a partnership with BMC. So they just covered a Signature Healthcare area. And Stewart is geographically a very large one. Partners Health System, which is an interesting one. Partners Health System is a large system with next to no presence in the BHCP project. Very small number of lives. So their folks are going to probably be spread out all over the place, but it's going to be small volume. But normally, most people receive their health care in the community they live.
Right.
It's like anything, there's probably always a few who, and particularly interestingly enough with BMC. In our initiative, there's actually 3 different BMC ACOs. There's BMC Boston, there's BMC South Coast, and there's BMC Signature. BMC South Coast is the St. Luke's, Charlton, Wareham Hospital System. And then Signature Healthcare is Brockton Hospital, and it's affiliated primary care practices. But the uniqueness about what BMC did is they actually have another ACO also in Central Mass, which is not part of our initiative. But BMC Boston covers all of Southeast Mass. So you can have members that are, say, in Brockton or in New Bedford or Fall River, that all their primary care relationships are in Boston, but they live in that community. But yeah, the service area model, makes a lot of sense. Certainly, the state is managed by service area also. So, good question. Yes.
Thank you.
Besides the first 3,000, is there a criteria for the other people who we'd be serving later?
Yes, it's actually on one of the slides. It's the same criteria. So the criteria to get on the criteria is written to get on the 65,000 list. And then what the state did is they said, okay, we have 65,000 eligible members. How are we going to attribute those members to the BHCPs? And this project, we've been working on this project now, I've been involved in this project for over 3 years. So for me, this has been a long, long road. I was actually part of the state strategic planning group that created the project. And that's where I was saying earlier about the, everyone wasn't happy. So the initial planning group was a group of hospitals, which became the ACOs, community-based providers, other interested stakeholders in the state, all sitting around a table talking about a model. And this became the model in the end of the day. But the 65,000 member list, is the criteria they came up with, which is really, to get on that list, your high behavioral health needs, high cost. Now, how they attribute it down to us, they came out with another criteria saying to be attributed to a member agency, you had to have, and I don't have it like all memorized, but for instance, if you got admitted into, like we operate, High Point operates detoxes. So if you got admitted to a High Point detox, say 3 or more times in the last 12 months, they're going to attribute that member to us. If you have an ongoing relationship in an outpatient practice, they're going to attribute that member to your group. So that's how these original lists are being done, is by attribution. So the 65,000 being carved down. I believe the slide had on it that at a 65, maybe it didn't, but 65,000 of the lives, only 15,000 had identified relationships. So the rest of them are really out there with all these needs, connected to nobody, and that's the group the ACOs are going to make the decision on who serves them. Okay? Great. Other questions? Yes?
You had for the Cape, Barnstable and Orleans listed, but what about the rest of the Cape? For towns, for services?
The service areas, it's a great question, because that, believe it or not, those two terms from the state is the whole Cape.
Okay.
Yeah. So when they use the term Barnstable, and certainly you'll get this level of detail, Barnstable has 12 towns under Barnstable. Yeah, I think you must be from the Cape, because the reality is Barnstable has a meaning to people on the Cape. I don't live on the Cape, so Barnstable's an area. You know?
I'm from Plymouth, but I've worked
Oh,
on the
okay.
Cape for the past 5 years.
Oh, okay. Yes.
In a homeless shelter.
Oh, okay.
And so
Yeah.
I'm like, wait a minute.
Right. Yeah, it's like one of the service areas called Plymouth.
Yeah.
But Plymouth is not the service area. Plymouth is the name they gave the service area. So it's the whole Cape. The only exception are the 2 islands, Nantucket and Martha's Vineyard. We just felt that there wasn't a need to have 5 different CP groups trying to manage 30 people on an island.
Yeah.
So we decided not to make it part of our proposal. Other questions? No. How are we doing time-wise?
Good.
So we got 10 minutes? No one has other questions?
I do.
Yes.
So will the ACOs be responsible for approved and identified services for a client? Do
You know,
what
that's
I
it.
mean?
Yes, I do know what you mean. That's an interesting question. Yes. So will the ACOs be responsible for identifying needed services for a client? And I'm going to say they may. However, they may not. Like, you know, that one chart where I said before, the ACO can refer right to a behavioral health provider. So they could do that. At the same token, you're going to have a member that you're looking at who receiving service and have some concerns like, gee, you know, they really would benefit from something else. And then you'd have to communicate really with both sides, the behavioral service side as well as the primary care side about, you know, recommendations for services. But absolutely, you're definitely going to be doing that assessment to figure out what else does this member need. Yep. So, good question. Thank you. Yes.
The list of names for October 1st,
Yes.
are those going to come from other organizations?
No, they're exclusively coming from Mass Health.
No, I meant from other organizations besides our partners.
No.
No. Okay.
No. Now, the list is just us, and the list will tell us which ACO the member is part of,
Okay.
which would be somewhat helpful. I really just wish they would list the historic relationship amongst our partners, because it's going to be a lot of work to figure that out. And then, you know, the other thing that we're still working with the software vendor on is there, you know, can we automate the uploading of that list into the software, and then electronically move the members into the 8 different agencies? And that's yet to be determined. Otherwise, once the list is done, you might be given, here's your members, and then you're gonna have to put them into the software. But you know, certainly the best that we can automate that process, we will. Other questions?
I have another one.
Yes.
since I work with the homeless population and you had Duffy listed, have you thought about a way to track the homeless people as they become, I work in a shelter and we place people.
Yeah.
And so once we place them, they often get lost because what happens is they lose services and things like that. And so often they become homeless again.
Yeah.
And so have you thought of a way to kind of track them and sort of help lessen that? So if they move out of the shelter in Bourne and say they're placed in Wareham, so now their services won't be based out of Hyannis anymore.
Yeah.
They'll be based somewhere out of Wareham. This is when they get lost in the shuffle.
And that's the whole reason for this project.
Right.
Seriously, that is the whole reason for this project, is that exact problem, that as members move around, they change providers, they go into one service and aren't connected to another service, they get lost. And ironically, that's our job. And once we start using the software to help manage that, that's where your recommendations and, okay, you know, we have this software product that, you know, you're kind of getting version 1 of, that over time, one of the things we're going to want to learn is, okay, how can we take this software and improve it, add to it, to make that part of the job more manageable? Yes, yeah. The other thing that I believe the majority of the agencies will be doing is also wrapping around recovery coaches and CSP workers, which is another community support program, which is more, which is kind of interesting because there's been a lot of chatter back and forth between the BHCP project and the CSP initiative, because the CSP person actually does some of the same tasks as the BHCP care coordinator, but they're actually more community-based out on the streets. So we are hoping to tie those folks to your hip, because I really think that for us to be successful, because the intent is that you're going to coordinate care permanently for 45 members. And, you know, in talking to different people, some models have more members, some models have less members. The reality is, you know, again, you can sit there and do the math, $180 times 45, and we were trying to come up with a number that we felt we could make this long-term sustainable, okay? In year 1, by the way, I mentioned the district money for startup. In year 1, we're anticipating on the operations side to lose $1 million. $1 million loss in year 1. So remember that $2 million change, or we're going to get in district money in year 1? We're going to probably spend 50% of that money on startup of ramping up and getting off the ground. You know, engaging folks, learning from that process, and continuing to get better at it. And that's the whole idea. The major, you know, why we have all those buckets, quite frankly, at the end of the day, the major use for district money is to give us dollars to support the project over the 5 years as we're ramping up and stabilizing to large enough scale to become self-supporting. So it's going to be interesting to see how the MCOs work with us around our idea of having CSP workers and recovery coaches attached to the majority of the members. So we might be in for a little bit of a fight at times on that. But that's nothing new. That happens quite regularly when you're trying to advocate. So, other questions?
I have another.
Sure, absolutely.
Is it 6 agencies or 8 agencies? I keep hearing you say.
Yeah, well, there's 2 different, it depends on what I'm referring to. So there's 6 affiliated partners, there's 2 material subcontractors, so there's 8 agencies overall. So it depends, at times I'll talk about the affiliated partners, which is 6, and then there's 8 agencies involved. Thank you, great question. Yes.
Confused.
Right, like what is the 6, what is the 8? Yes. And the difference in the other 2 agencies is they're not part of governance. But the other critically important thing is they actually are they are in an ACO. So they're part of the C3 ACO, which is one of the Model B ACOs. So basically, in that model, for all intents and purposes, what we're doing is actually doing what we fought not to have happen. Strange, but true. Because you remember, back when we were working on the planning of creating the BHCP project, a lot of the ACOs didn't want us. They said we should do all the care coordination. There's no need to have these behavioral health providers involved at all. And when we were approached by C3 to work with their 2 health centers, it was a tough call to work with them or not. But we felt that because the whole project really is an experimental model, that we felt by having that unique niche to our model as part of a carve-out made sense. So we can also learn from that. At the same time, we will have a number of members that are served by our subcontractors for primary care that you're serving as the BHCP partner. So they're not exclusively serving all the folks that are going to their health center. But the reality is they are serving some of them, where no other ACO has that type of relationship with us. Other questions?
I have one.
Yes.
You were talking about the CSP workers.
Yes.
And how, we're not sure how that's gonna fit in.
Well, I know how it's going to fit out. I'm not sure if the MCOs are all going to agree with us that we feel that, you know, they're going to agree with us that it always makes sense.
Oh, okay.
Yes.
So we would be working together with CSP folks.
Absolutely.
Okay.
Yes.
And then, so like at Duffy's Health Center, we have housing first case managers
Yes.
who bill through CSPEC, through Mass
Right,
Health.
right.
I'm wondering if some of those folks who are chronically homeless, who are living in the woods, are
Yeah.
gonna be referred to this program.
Yes.
And we can double bill like that?
Well, be careful here. We don't call this double. Is that double billing? This is what it
But
is.
is it, so then we have 2 people working with them from the same agency?
Yes, absolutely. And the reality is this is an argument we already had with the MCOs. We haven't gone live yet,
I know.
and we're already having these conversations. We've had these conversations ad nauseum with Mass Health.
Okay.
Here's the cool thing. Mass Health understands the difference between your role as a care coordinator for BHCP versus the role of the CSPEC staff member.
Okay.
They understand the difference between those two, so they do not believe it's duplication of service.
Okay.
The important thing for us on our side is, because we have two of the agencies that do in CSPEC, at least 3 are doing CSP, and a couple are doing recovery coaches. And then there's actually a new benefit that starts July 1, which is a navigator. Okay? So we are going to have to continue to look at all these different Mass Health benefits for members and see how do they fit into this initiative. Because the Mass Health member has the ability to access a whole list of services. And, the service that's done inside this program is very, very narrow in its focus. And I think it could be very easy for care coordinators to starting to fulfill the role of a CSPEC staff member or a CSP staff member. The thing you're going to find out very quickly is you don't have the time to do that. You have a caseload of 45, okay? And you have some people coming and going, you're trying to locate them because they moved to another service. So while you'd love to do the work of that CSPEC employee, you won't be able to. And that's going to be part of the learning curve collectively for all of us, is where we draw on a line in the sand. Because if you start doing too much, you're going to get overwhelmed. And ironically, the client's not going to get their needs met. But thanks for asking, because it's a great example. But definitely that's really where the friction is going to come with the MCOs. Well, they have that. Why did he need this? And that's where, our continued education of the MCOs and the Mass Health's education of the MCOs is going to become critically important.
I think
Yeah.
that helps with the explanation that our role will be different from that, so that's
Absolutely.
important to remember.
The other complexity of roles is the ACO side. Because depending on which ACO you're working with, the ACO at times are also going to have a care coordinator. Okay? So now you have, think about this. You have an ACO care coordinator, you have a BHCP care coordinator, and then you have a CSP worker, you have an outpatient clinician, and you have a psychiatrist. Right? So that's 5, and that's before you get into any other specialty needs of that client. So there can be other specialty providers that are not on that list of 5, but for most of the members, you're going to have at least 4 different entities involved, but it's not 4 different people. When you're talking about that the ACO has a care coordinator, well, that ACO has other people that they could have at the table that you're also talking to. And I do think that there's going to be a lot of back and forth with the ACOs, what their role is on care coordination versus what our role is. And certainly at times there's going to be a lot of shared responsibility is what it comes down to. Some of the ACOs, because again, particularly the Model A's, are at risk for total cost of care. So if they're nervous that our care coordinators have too much on their plate and are dropping the ball on things, they're going to continue trying to manage that client. And over time, honestly, they're going to use that as an argument of why they shouldn't work with the BHCPs at all. Now, some of the ACOs, ironically, are going to take the opposite approach and say, great, you have a care coordinator? Our care coordinator is going away, and you're the care coordinator. So you're going to see both happen. You're going to see ACOs that are very intensely continuing to do care coordination, and other ones that are totally going to depend upon you collectively to do that care coordination. And like I said, every ACO is going to be different. So it's important that we begin to understand those differences, document those differences, and learn from those differences. Other questions? Yes?
Has Mass Health explained that there's going to be this new initiative and there's going to be new care coordinators to the ACOs?
Yes.
So they're aware?
Very much so.
Okay.
In fact, we actually, since we meet every month, the BHCPs, the ACOs, and Mass Health has been meeting every month since last September
Oh, okay.
as a group. And definitely there's been many, obviously these are in-person meetings, but then there's been many conference calls between those groups also. Yes. So I think the bigger challenge is really how has each of the ACOs been doing and filtering that information down through their PCC practice, their primary care practices. Because that's really where the work's going to happen, is at that level. And you get a member that you need to reach out to get the primary care practice to sign off on a treatment plan, and you're going like, I don't know who you are. I don't know what BHCP is. So I do think we're going to run into some need to educate at the PCC level with some of the ACOs, because they just haven't gotten to every one of their practices and every one of the people inside those practices. Yeah. So, thanks. Other questions? No? No? Well, I think it's time for a break. Thank you all. I appreciate it.
You can all take a 15-minute break. You can go outside, whatever.
Oh.